Live from Boston, my name is Emilio Madrigal. Today, I'm delighted to welcome back my colleague here at MGH, Dr. Judith Ferry, who is the Director of Hematopathology and a Professor of Pathology at Harvard Medical School. Dr. Ferry was recently inducted as the first incumbent of the Nancy Lee Harris, MD, Endowed Chair in Pathology here at Mass General Hospital. And she's also the author of a book titled Parallel Lives. Today, Dr. Ferry will be presenting a hematopathology talk titled Cutaneous B-cell lymphomas and their differential diagnoses. As always, please feel free to post comments, questions in the Facebook and YouTube chat windows, and we'll make sure to pass those along to Dr. Ferry at the end of the session. So with that short introduction, I'll pass the microphone over to Dr. Ferry.
Thank you very much for that kind introduction, Dr. Madrigal, and thanks to all of you who have taken the time to sit on in this short lecture on cutaneous B-cell lymphomas and their differential diagnosis. So let's get started. Let's see if I can make my, there we go. I have no disclosures. This is the first case I'd like to show. This is the case of a middle-aged woman who was reported to have a lesion of her posterior shoulder. She was otherwise completely well. And what you can see in these images are perivascular and periadnexal collections of lymphoid cells. The epidermis is uninvolved. If you look on higher power at one of these lymphoid aggregates, the cells are mostly small, round to slightly irregular. They have a little bit of pale cytoplasm, but basically quite bland. When we immunophenotype this, we found aggregates of CD20 positive B cells. T cells were mostly disposed around the periphery of the aggregates of B cells, and there is background with kappa and lambda immunohistochemistry, but it looks like there are polytypic plasma cells scattered in the infiltrate. So this was signed out with a diagnosis of dense lymphoid infiltrate. Low-grade B-cell lymphoma is a possibility, but the findings are not diagnostic. So time went by, and 16 months later, the patient came back this time with a larger lesion in the same area, and it was biopsied. And you see here with this punch biopsy, the epidermis is again uninvolved, and the aggregates that we saw before are now larger and more crowded and go deeper into the dermis. And we'll take a closer look at that. And here again, the epidermis is beautifully uninvolved, and we have a dense infiltrate of small lymphoid cells, perhaps a few pale admixed histiocytes. And if you look up here and then over here, just beneath the epidermis, there are a fair number of plasma cells. You can see them here with their, there's a binucleate one, it looks like here, with their eccentric nuclei. Here's one nice dark nucleus, eccentric cytoplasm with the suggestion of a Golgi. So a lot of plasma cells in the infiltrate. And so we immunophenotyped this, and we found that there were many B cells in large aggregates. Here was CD20. We see the same pattern that we saw earlier with CD3, with T cells tending to be around the periphery of aggregates of B cells. And we identified small germinal centers within the aggregates of B cells. So here's a small germinal center that is BCL6 positive and negative for BCL2. So an appropriate staining pattern for a small reactive germinal center. Now, when we have in situ hybridization for kappa and lambda, we see that there are only very rare kappa positive cells, but many lambda positive cells. So that's very convincing for a monotypic population of lambda positive plasma cells. When we looked at staining for heavy chains, we found that most of the plasma cells are IgG positive, and they are also, not only are they IgG positive, but they're IgG4 positive, and you can see that there. And so our diagnosis was cutaneous marginal zone lymphoma of mucosa-associated lymphoid tissue, also known as Malt lymphoma. It shows plasmacytic differentiation, which happens to be IgG4 lambda positive. Primary cutaneous Malt lymphoma has distinctive clinical and pathologic features. It represents 30 to 40% of all primary cutaneous B-cell lymphomas, so it's an important one to know about. It mainly affects middle-aged and older adults, but has been found occasionally in children and adolescents, and there is a male predominance. The etiology is not really certain. Possibilities of some sort of chronic antigenic stimulation has been raised. Possible autoimmune disease underlying has been suggested. In parts of Europe, there have been reports of underlying infection with Borrelia burgdorferi, but in the United States, that does not seem to be a factor. But there are no known specific risk factors in the vast majority of cases. The lesions tend to affect the trunk and the upper arms, but they can be found in other anatomic sites. And what one usually sees clinically are multiple or sometimes single reddish papules or nodules. Recurrences are common, but extracutaneous spread is rare, and the prognosis is overall really excellent. As far as pathologic features, one sees a dense multinodular infiltrate involving the dermis. Sometimes the subcutaneous tissue is also involved. One sees at high power small lymphocytes, small lymphoid cells with pale cytoplasm. Plasma cells are often present, and there may be small reactive germinal centers. The epidermis is typically spared. Lymphoepithelial lesions are not a conspicuous finding, and monocytoid B cells, such as you might see in Malt lymphomas, say in the salivary gland, are also not conspicuous in cutaneous marginal zone lymphomas. The neoplastic cells are CD20 positive B cells. They are negative for CD5, CD10, BCL6, and cyclin D1. Clonal plasma cells are often present, and really that's how we identify a lot of these cases. The Ki67 proliferation index is low among the B cells. There are frequently admixed reactive germinal centers, and those are CD10 variably positive, BCL6 positive, BCL2 negative. They are associated with follicular dendritic cell meshworks, and the proliferation index is high. As far as underlying genetic events, fairly common findings include mutations of the FAST gene, or methylation methylation of the promoters of DAPK1 and CDKN2A. The MyD88 L265P mutation that is commonly found in lymphoplasmacytic lymphoma and primary cutaneous diffuse large B-cell lymphoma of Lake type is absent. And translocations of IgH, MALT1, BCL2, BERK3, BCL10 are either rare or absent. We don't expect to see them. Let's look at another example of Malt lymphoma. In this particular image on the left, there's a single sort of violaceous raised papule. It has sort of a multinodular surface. And there on the right is a patient with multiple lesions. And there's one large one here, one large one here. But then I think there's sort of almost little satellite lesions away from the main lesion. When you look at primary cutaneous Malt lymphomas with plasmacytic differentiation, you can divide them into class-switched cases and non-class switched cases. So by class-switched, which make up the majority of cases, that means that the plasma cells that are there are not IgM positive. B cells start out expressing IgM, and then some of them switch over to being IgG, IgA, or IgE positive. So those are class switched. And when we look at the plasma cells, we can see whether or not it's very easy then to tell if there's been class switch. So in the class switch cases, you get a discontinuous lymphoid infiltrate, which I think we saw in our case. T cells are relatively abundant, and sometimes they even predominate over the B cells, even more numerous than the B cells. And these cases are virtually always localized to the skin, and they stay there. Now, in the minority of cases that are non-class switched, any clonal plasma cells that you have are positive for IgM. The infiltrate is more likely to be confluent, more likely to have a significant predominance of B cells with a lower proportion of T cells. And while such cases may be primary in the skin, it's also not uncommon to be able to find extracutaneous disease as well. So it's possible that some cases of Malt lymphoma involving the skin with IgM positive plasma cells represent metastasis from some other extracutaneous primary Malt lymphoma. Now, the case I showed at first expressed IgG4, and it turns out that there's a disproportionately high percent of primary cutaneous Malt lymphomas that express IgG4. IgG4, just based on serum, it represents about 5% of the different IgG classes. And so to have anything more than about 5% of cases positive is really disproportionate. But in the skin, in different studies, between 13 and 39% of all cutaneous Malt lymphomas have been IgG4 positive. So not really sure why that's happening, but it is kind of a distinctive feature. And this same phenomenon has been described in Malt lymphomas arising in the dura mater. But IgG4 expression is rare among other Malt lymphomas, lymphomas arising in other sites. And importantly, just because you find clonal IgG4 positive plasma cells, it does not mean that the patient has IgG4 related disease. Another interesting thing that you see with Malt lymphomas with plasmacytic differentiation, the clonal plasma cells often have this necklace pattern. So they are arrayed around the periphery of the aggregates of lymphoid cells in many cases. And here you can see that. We have kappa staining in an irregular necklace around an aggregate of lymphoid cells. Lambda positive plasma cells are very rare. And then IgG stains in a pattern similar to that of kappa. And then IgM stains just a few cells. So anyway, so be on the lookout for this necklace pattern. As far as the differential diagnosis of primary cutaneous marginal zone lymphoma, it's always important to consider the possibility that it may have spread from another site. And I typically will put in the end of my pathology report I recommend staging as clinically indicated to exclude an extracutaneous primary. Reactive lymphoid infiltrates may be less dense. They may not have a Gren zone. They typically do not have a large population of B cells outside follicles. They would not have clonal plasma cells, and they would not have clonal rearrangement of the immunoglobulin heavy chain genes. Rosai Dorfman disease can sometimes come into the differential of cutaneous Malt lymphoma. And in Rosai Dorfman disease, you see a dense lymphoplasmacytic infiltrate. It does contain many B cells, but there's the distinctive histiocytes that should clue you into the diagnosis, although these may be focal or patchy. The plasma cells are polytypic, and you do not have clonal immunoglobulin heavy chain gene rearrangement. Primary cutaneous follicle-centered lymphoma is also in the differential diagnosis, but lymphoid follicles are more extensive. You're more likely to have atypical follicle center cells outside of follicles. There are few plasma cells in the infiltrate, and they are certainly not clonal. Diffuse large B-cell lymphoma contains large cells that are not confined to germinal centers. They are instead present diffusely. And then classic Hodgkin lymphoma. So Hodgkin lymphoma is vanishingly rare in the skin. I saw a case not too long ago, but it turned out it was growing from a nodal lesion or a mediastinal mass and had grown all the way out into the skin. So really not primary in the skin. So view it with suspicion before you make such a diagnosis. Now, importantly, there was an interesting paper published recently, the reference is down here, that shows that described cases of primary cutaneous marginal zone lymphoma containing CD30 positive and CD15 positive large cells, and saying that they could mimic classic Hodgkin lymphoma. So be on the lookout for that and be suspicious before you make a diagnosis of primary cutaneous Hodgkin lymphoma. Finding clonal plasma cells and clonal immunoglobulin heavy chain gene rearrangement would support marginal zone lymphoma and would exclude classic Hodgkin lymphoma. So let's look at this case. 10-year-old boy, lesion of the scalp. You see, well, typical of scalp, we have these well-developed hair follicles, and here we have a dense lymphoplasmacytic infiltrate. So it's quite an extensive infiltrate, goes quite deeply into the dermis. And when we look around, we see that there are many small lymphocytes. Here in the left panel, you can see that there's a reactive germinal center. It's a little bit irregular, but it looks like a reactive germinal center. And then in other areas of the infiltrate, in addition to small lymphocytes, there's many plasma cells. You can see plasma cells all over the place. Some of them have the appearance of Mott cells with multiple globules of cytoplasmic immunoglobulin within the cytoplasm. And so a lot of lymphocytes, plasma cells, germinal centers, big lesion. Could it be Malt lymphoma? So here we have CD20, and there's a lot of B cells, and there are T cells, and they tend to be in this sort of pattern surrounding aggregates of B cells. But when we look at the plasma cells, they look to be polytypic. There's a little bit more kappa than lambda, but that's kind of the normal ratio. So what is this? So let's go back to the H&E. And there were aggregates of these histiocytes with abundant pale cytoplasm. And if you look at them at a little higher power, you can see that many of them have these large nuclei with vesicular chromatin and prominent nucleoli. So they look a little bit atypical and certainly quite activated. And there's a number of those large nuclei scattered around. And with some imagination, I think that you could convince yourself that there are small lymphocytes within the abundant pale cytoplasm of these large histiocytes. And so this would be emperipolesis. Here's another pretty good area where you have the histiocyte nucleus and then a small lymphocyte there within the histiocyte cytoplasm. So let's see if we can prove that. I'll also mention that flow cytometry showed no abnormal population of lymphoid cells, and there was no clonal rearrangement of the immunoglobulin heavy chain gene. And when you look with S100, those distinctive histiocytes are strongly positive. And if you look at higher power, you can see that if you focus on an individual histiocyte, there are negative lymphocytes within the cytoplasm of this single large histiocyte. So it's exactly the pattern that you want to see in Rosai-Dorfman disease. So this young child does not have lymphoma. He has Rosai-Dorfman disease, which would be much more common at his age than Malt lymphoma. Let's look at another entity that might enter the differential diagnosis of Malt lymphoma. This is the case of a middle-aged man with numerous lesions of his torso, and you can see them there. They're little raised reddish-brown lesions. The clinical differential included lichen planus and granuloma annulare. And in another area, the lesions almost look a little bit warty. They have kind of a flesh-colored tone to them, so a little bit varied, but innumerable lesions over the patient's torso. So we look at the biopsy, and you can see here that there's a dense lichenoid infiltrate of lymphoid cells, and then deep to that lichenoid layer, there is some perivascular and periadnexal extension of the lymphoid infiltrate, and it doesn't go terribly deep. And in addition to lymphocytes, if you look on higher power, you can see that there are numerous plasma cells within the infiltrate. So could it be Malt lymphoma? When we look at immunophenotyping, you can see that there are numerous B cells and fewer T cells. So that would raise the question of lymphoma. But if you look with in situ hybridization for kappa and lambda, the plasma cells are beautifully polytypic. And if you had a Malt lymphoma in the skin with that many plasma cells, you would really be shocked if the plasma cells were not clonal. But here, these plasma cells are polytypic. So that speaks against Malt lymphoma. Another thing against Malt lymphoma, if you look at the epidermis, there's a lot of exocytosis of these small lymphoid cells into the epidermis, which we really don't expect to see in Malt lymphoma. And here again, many of these plasma cells in the infiltrate. So what could this be? We solve this with a stain for spirochetes. And it turns out that there are numerous treponema here, seen best in the epidermis in these images, just innumerable within the epidermis. So this is an example of syphilis. And given the distribution of the lesions, we'd expect this to be secondary syphilis. So not Malt lymphoma, easily cured with antibiotics, I think, and but important to get the diagnosis right. Now let's turn to another case. This is a 50-year-old man who has a lesion of the scalp. He's otherwise well. And you can see we certainly can't complain that the dermatologist or the surgeon did not give us enough tissue in this case. So we see a very dense, extensive lymphoid infiltrate filling the dermis. And then you can see a little bit of residual subcutaneous tissue here. So this infiltrate goes way down in through the subcutaneous fat and maybe is down to underlying dense soft tissue. If you look at the epidermis, in this case, the epidermis is spared and the lymphoid infiltrate starts really get going in the sort of mid to deep dermis. And if we look around in the center of the lesion, you can see that there's an extensive atypical lymphoid infiltrate. There are some aggregates of small lymphoid cells, but the rest of these are atypical lymphoid cells in these broad swaths and sort of irregular aggregates. And here we see atypical lymphoid cells streaming through dense connective tissue. In some areas in the infiltrate, you could see that there are atypical follicles. And here's an irregular follicle here. Here's a small round follicle, but they don't have the composition of reactive follicles. They look atypical, and there's some overlap with what we saw in what appeared to be a diffuse component morphologically. And then in other areas in the diffuse component, we just take a good look at these atypical cells. So they're certainly larger than normal small lymphocytes, and they're overall irregular, somewhat irregular, sometimes distinctly lobated nuclei. Sometimes they have elongate nuclei. You can see them here again, this sort of irregular indented contour of these cells. And when we immunophenotype this, we see that the atypical cells are CD20. So we're on pretty firm ground saying that this is a B-cell lymphoma. When we look with the follicular dendritic cell marker CD21, it does turn out that there are some little follicular dendritic cell meshworks within the lymphoma. And then there's also a decent component of small T cells highlighted here with CD3. And as we continue our immunophenotyping, we see that there are many CD10 positive cells in the infiltrate, many BCL6 positive cells in the infiltrate. So we do have a follicle-centered immunophenotype here. And then in some areas of the infiltrate, the atypical B cells are negative for BCL2. In other areas, they are weakly positive for BCL2. So our diagnosis in this case is primary cutaneous follicle-centered lymphoma. The clinical features of primary cutaneous follicle-centered lymphoma include that they are the most common primary cutaneous B-cell lymphoma that one is likely to encounter, mainly affects middle-aged adults. There's a slight male predominance. Patients may have a single lesion, or they may have more than one group of localized lesion. The patients usually have involvement of the head and neck, and sites that one is especially likely to see these lesions are on the scalp or on the forehead, but they can also occur on the trunk. The legs are uncommonly involved, and to have multifocal lesions in more than one anatomic site is fairly uncommon. Clinically, these lesions have the appearance of reddish plaques or nodules, or they may form large tumors, like in the case that I showed. Recurrences are relatively common, but they're mainly in the skin. Extracutaneous spread is uncommon, and the prognosis is overall excellent. Although strangely, when primary cutaneous follicle-centered lymphoma occurs on the leg, the prognosis is less good. Microscopically, one sees large perivascular and periadnexal aggregates or nodules or diffuse infiltrates involving the dermis and sometimes the subcutaneous tissue. And the lesions can have a follicular or a follicular and diffuse or a diffuse pattern. The diffuse pattern, entirely diffuse pattern, tends to be with lesions that have been present longer, seems to acquire a diffuse pattern over time. Sometimes one sees the follicles are often somewhat ill-defined, or they don't have good mantles, or they can have an inside-out pattern where you have follicle center cells wrapped around a core of small lymphocytes. So, and again, the mantles are typically attenuated, or they may be completely absent. The epidermis is spared, and the cellular composition is typically a mixture of small and large centrocytes, and there is a variable admixture of centroblasts. The composition tends to be more monotonous than that of reactive follicles. You can have multilobated cells. You can have elongate spindle cells in some cases. The immunophenotype of the neoplastic cells, they are CD20 positive. They are negative for CD5. They are variably positive for CD10. It turns out that CD10 is more commonly seen in cases that still have a component of with follicle formation. Entirely diffuse cases have more of a tendency to lose CD10 expression. BCL6 is consistently expressed. Cyclin D1 is negative. BCL2 is typically negative or weak. Expression of BCL2 by the neoplastic cells does not exclude the diagnosis, but one should really carefully consider the possibility of a systemic primary that has secondarily spread to involve the skin. The Ki67 proliferation index is quite variable, and it can be quite high. It can be a little frightening when you first encounter these high proliferation index in primary cutaneous follicle-centered lymphoma, but it really does not portend an ominous prognosis. And when you have follicle formation, those follicles will typically be accompanied by follicular dendritic cell meshworks. And as far as genetic changes, one has a clonal immunoglobulin heavy chain gene rearrangement, but there is somatic hypermutation, which is true of follicle-centered lymphomas in other sites as well. Another common change is deletion of the oncogene ACT1. Mutation of CREB-P and KMT2A is found in primary cutaneous follicle-centered lymphoma, but it is less frequent than in systemic or primary nodal follicular lymphoma. The BCL2 gene is rearranged in only a minority of cases, and in such cases, there is a higher risk of systemic spread. So maybe defining a little bit of a different subtype of primary cutaneous follicle-centered lymphoma. And the MYD88 L265P mutation is not found. So as far as the differential diagnosis, we should always consider the possibility of a systemic follicular lymphoma, especially in those cases that have strong BCL2 and strong CD10. Reactive lymphoid infiltrates also enter the differential. Excuse me a moment. Also enter the differential diagnosis when there is a prominent follicular component. But in reactive lymphoid infiltrates, the lymphoid follicles are more likely to be discrete, more likely to have intact mantles, and more likely to have B cells mainly confined to the follicles. Malt lymphoma can enter the differential, but usually follicles are a minority of the infiltrate, and clonal plasma cells are common, which you should not see in follicle-centered lymphoma. Primary cutaneous diffuse large B-cell lymphoma of leg type is more commonly found on the lower extremities, in contrast to the distribution on the scalp and the forehead that is typical of follicle-centered lymphoma. So the neoplastic cells are round to oval with vesicular chromatin and prominent nucleoli. They don't have that irregular, elongate, or lobated nuclear appearance that you see with follicle-centered lymphoma. Their immunophenotype is as follows. They are CD20 positive B cells, but they are negative for CD10, positive for BCL2, positive for MUM1, positive for IgM, and then BCL6 is variable. There's no follicle formation, and the MyD88L265P mutation is commonly found. And common genetic changes include losses of CDKN2A, CDKN2B, and TNF-AIP3. One may also see amplifications of chromosome 18q21, which is the location of the BCL2 gene. And this lymphoma is associated with much more aggressive behavior than follicle-centered lymphoma or of Malt lymphoma. So here's an example just for comparison of primary cutaneous diffuse large B-cell lymphoma leg type. And you can see that there is, again, a dense lymphoid infiltrate. It's sparing the epidermis and is heavily involving the dermis and the subcutaneous tissue. There is a nodularity to the infiltrate, but these are not follicles. They're just sort of following, I think, the tissue planes of the skin. And on high power, the neoplastic cells have round to oval nuclear contours. The chromatin is vesicular, and you can also see some prominent nucleoli. And this lymphoma is also strongly positive for CD20, like other B-cell lymphomas, but it has a very high proliferation index with Ki67. And if I can just mention a few so-called pearls. The differential diagnosis of primary cutaneous marginal zone lymphoma and primary cutaneous follicle-centered lymphoma includes other types of lymphoma, as well as reactive lymphoid infiltrates of various types. To suggest an immunohistochemistry panel, I would say optimally one should do CD20, CD3, CD5, CD10, BCL6, CD21, Ki67, kappa, and lambda. If the B cells are CD5 positive, I would add cyclin D1 to exclude mantle cell lymphoma and LEF1 to investigate small lymphocytic lymphoma, chronic lymphocytic leukemia. I'd also check what the CBC is and see if there's a lymphocytosis. Identifying clonal plasma cells often clinches a diagnosis of cutaneous Malt lymphoma. If the plasma cells are clonal, consider adding immunohistochemistry for immunoglobulin heavy chain genes. And importantly, the diagnosis may not be apparent on the first biopsy. The lesions don't always declare themselves right away, and clinical correlation is essential. We have a very helpful multidisciplinary conference once a month where we discuss difficult cutaneous lymphoid infiltrates, and I think that's a very helpful thing. So that's all I have to say about the differential diagnosis of cutaneous B-cell lymphomas. If you found this talk informative, I'd like to bring to your attention our 43rd annual course, Current Concepts in Surgical Pathology. This is going to be a live stream course held October 24th to October 28th of this year. And where you can register is shown there in the slide to the right. You can just look up Harvard Medical School HME courses. So I hope that you'll check out our conference, and I hope that you enjoyed this talk on cutaneous B-cell lymphomas. Thank you very much for your kind attention. I'm here.
All right, thank you so much, Dr. Ferry. That was a wonderful lecture. Just to let you know, we've had viewers from all over the world, Bolivia, just some of the folks that I'm seeing here that made comments, and thank you for your lecture. So Bolivia, Iraq, someone from Miami,
Wow.
Florida, Pennsylvania. There's just folks from all over the place. I'm not seeing any questions right now, but usually, we do get questions after the fact. So if anything comes up, I'll let you know. But again, thank you so much
Okay.
for the session. Really appreciate
My
it.
pleasure. Yeah.
All right, take care. Thank